married, and then their ages range between 28 to 55 years. Majority of them had a diploma degree in the midwifery profession or the community health nursing profession from ANC from 1 to 7 years. And our inclusion criteria I must say was that they should have been involved in providing care in the period. So after our analysis, we came up with 3 themes. The first one talks about the demanding nature of the care that the pregnant women doing the is about balancing benefits and risk, and then the third and final one regards theme, that is the demanding nature of the antenatal care experience. According to the midwives and the community health nurse, there were increased pregnancies during the period. Had to report for antenatal care. Some of the staff also contracted COVID themselves, and so they were excused duty. This meant that there were minimal amount of staff available to take care of these pregnant women. And some of the staff also had changes in their working schedule, and so they had to work longer hours. And then during the period also, there were no annual leaves. And so it meant that those who were without COVID had to sort of stay on and on. Also, they acknowledged that the length of time they spent on each pregnant woman had also increased because they had to observe the COVID protocols in addition to the usual care that they give to the pregnant women. And so all of these factors resulted in tiredness, easy fatigability, and also burnout among them. And so these are some of the quotes that they use to describe some of their experiences. Because of time, maybe I'll just take one of them. So one participant said that now, frankly speaking, they spend a lot of time here. The hand washing takes time because we have several Veronica buckets at almost every place. At first, we were doing things a bit faster, but now we do COVID-19 education, so it takes time. Then on the second theme, that was on balancing benefits and risk. For those who do not know, nurses and midwives pledge, and they pledge to take care of the sick with all the skill they possess, irrespective of their race, creed, color, political or social status, sparing no effort to conserve life and alleviate pain, and also to promote health. And here was where they found themselves in a very difficult situation because they were taking care of unsuspecting, in quote, pregnant women against risk to their own lives and also risk to their family members and loved ones. In spite of all these personal discomforts also that they experience, especially with prolonged wearing of nose mask, the nurses and midwives were still passionate and resilient in providing care to pregnant women in these times. We now move on to the third and final theme, which talks about changes in care. As a result of the pandemic, several changes were made in the care that they were providing. Because of the large number of women who were reporting for antenatal care, they had to make do with makeshift consultation rooms and also provide some additional resources which the hospitals supported. They also now had to wear masks and try their possible best to observe social distancing, even when sometimes it was impossible to do so because of the numbers and the limited space that they work. They also had to use measures to minimize contacts so as to protect themselves and their clients. So they move from, in some situations, from using the manual fetoscope to using a Doppler to check the fetal heart rate of the babies. And then they also recognize that they had to raise their voice. You know, once you have the mask on, it means that you have to speak a little bit louder than you normally do so as to be heard. And also because of the social distancing, it means that they had to make extra efforts to reach their clients. They also acknowledge improved midwife-client communication because they exchange contact numbers with their clients and they try their possible best to provide telephone support as much as possible. And as we know, Ghana, we are practicing the focused antenatal, and so each client is assigned to one particular nurse or midwife who is responsible for their care throughout the period. And so, in conclusion, we'd like to say that nurses and midwives who were caring for pregnant women during the pandemic were overwhelmed with work amidst fears for their own lives and that of their family. And in spite of all these, they still kept on. We recommend psychological support and also the provision of adequate human and material resources to minimize the effects, the negative effects of the pandemic on their personal and professional lives. And as we heard this morning, that we shouldn't only look at the challenges, but we should also look at the opportunities that the COVID presents us in terms of changing or modifying how we provide care. And I think that the clarion call is also on nurses and maybe midwives and even the entire healthcare system to look for other models of providing antenatal care, not just by using the telephone, but we can also in the future try and look at remote monitoring of the woman, whereby they can be wearing some wearable devices. So for instance, a watch or something, and then if the watch helps them to provide or monitor their babies and only to report when there is the need, I think all of these things will help us. I must also acknowledge some limitations of our work, and as it is a qualitative work, we are not hoping to generalize our findings to the entire nation, but we hope that they can be transferable to settings that are similar to the ones that we use. We also acknowledge recall bias because we started the data collection last year, that is December 2020 to this year, April 2021, and so we acknowledge that perhaps they might not really recall exactly all the things that happened during the period. But in spite of all this, we think that the experiences that they shared are important to note and that we need to look at how best we can make them in the future. And so these are some few references. And I'd like to say thank you very much for giving me the audience. Thank you. Oh, you should clap for me.
Thank you very much. Thank you very much. So you can have a seat. We'll call you after all the presentations so that we take questions from the audience. Our next presentation is from Hammond D, talking on blood donor knowledge, practices, perceptions about blood donation during COVID-19 pandemic. So you can come here. And if you are a presenter and you are here, I think Saki E, please let's have your drive, yes, and then we can load it. Thanks.
I'm Doris Simon presenting on donors knowledge, practice, expectation. pandemic. And as we all know, blood is life, and as such is the body's fuel. Without it, the body cannot live. And we've realized that COVID has had impact on blood supply. So we need to know donors' knowledge, their practice and expectation on it. Blood, as we all know, is a primary fluid for gases, nutrients, sodium, factors, gases, heat, and respiratory, especially between cells and respiratory organs. We also notice that functionally, the body needs adequate supply of blood, and persons lacking a critical quantity of blood need urgent supplementation in the form of blood or blood products. We need to transfuse them in the form of transfusion. And blood cannot be manufactured. The only way for it is through human, and it's through transfusion. Human are the only source of blood transfusion. And in Ghana, much of the blood donated in developing countries are for managing children with severe anemia and pregnancy-related bleeding. In Ghana, about more than 75% of the blood donated in rural areas and 50% in urban areas are used to treat children under 5 years and women of childbearing age. Before the COVID, there was already existing insufficient supply of blood, but the COVID posed more prices on blood supply. It reduced blood donation. People were afraid of contracting the disease, so they were not coming out. They refrained from donation, and it became a huge problem. The pandemic had negative impact on the economy, and blood transfusion was no exemption. It reflected in the blood. The measures, because of the spread of the COVID, government made an effort to put in measures, preventive measures, to curb the spread of the pandemic. And what we realized was that the measures that was put in place has some impact or negative impact on our donors. We realized that some were afraid to come out to come and donate, and some also thought the COVID was a mythical disease, quoted unquote, and that when they come, one way or the other is in the atmosphere, and that they might contract it and infect their family at home. So they will not even come at all to the blood service to come and donate. And in fact, it threatens the safety of both donors and recipients, because recipients also thought the COVID could be transmitted through blood. So even when they needed the blood and want to transfuse them, they refuse transfusion. So we then asked ourselves, how do we then maintain blood donation in the pandemic like COVID? And we decided to make a study, and the study was a cross-sectional study. We targeted 2 most affected cities in the country, that is Kumasi and Accra. And specifically, we did a study at National Blood Service, 37 Military Hospital, Police Hospital, and Konfanoche Hospital. What we did was, we designed a questionnaire and added to the already existed donor screening questionnaire. And the questionnaire was in a multiple choice question. We grouped them into 3: the donor's knowledge, their practice, and expectation. And we also contacted those who had not honored their invitation for voluntary donation for the past 6 months. We contacted them on phone, and we administered this questionnaire to them. In all, we recruited 615 donors. And we realized that males dominated the study, with majority of the participants between the ages of 31 and 40. And we also realized that majority of them were replacement donors, and they were recruited at first sight. If you say first sight, we mean those who came to the blood service to come and donate blood, who didn't honor their invitation for the past 6 months. We called them on phone and administered the questionnaire to them. We realized that age, participant gender, age, the donor type, and the recruitment type were all significant. And we also asked them, when donors were asked whether they've heard about COVID-19, we realized that all the participants have heard of COVID-19. And this could be due to the fact that the devastating effects of COVID-19 made it popular and was available on all platforms, both local and international. And so we realized that they all know at least something about COVID-19. And when they were asked of what kind of disease they think the COVID was, majority of them could correctly answer that COVID-19 was not a mystical disease. Neither was it an imaginary disease, an European or Chinese disease. But they could correctly answer that COVID-19 was a lung disease, a viral disease, and it was a pandemic. We went ahead and found out from the participants how the disease could be transmitted. And they were able to answer, majority of them had it right, that the COVID-19 could be transmitted through saliva, air, and hands. And they answered correctly that it could not be transmitted through sex and blood. When participants were asked regarding the manifestation of the disease, majority, as we always say, were able to answer correctly that the manifestation was fever, cough, and sexual weakness. They got it correct by answering that the manifestation of the disease was not weight loss. We also found out their perception about donation during the pandemic. And they answered correctly that they thought or think COVID-19, during the COVID-19, a donor can contaminate a recipient. And we asked whether they thought there was a risk coming to donate blood during the pandemic. They also said there was a risk, and that you could be contaminated by someone or something. When they come to the blood service, the bed they lie on, they didn't think the bed sheet was changed after every donor. So if a donor lies on it, that was their perception, and the person has COVID-19, the probability of them lying on the same bed sheet was high. So they thought there could be a contamination, so they refrained from coming to donate blood. And some also thought they could be infected with HIV during the pandemic. Some thought they could faint, and on their way to the blood service, they could have an accident, so they will not come and donate. So after the interview, we scored them, and using a cutoff of 58%, we realized that about 92.5% of them had adequate knowledge about the COVID-19, and 53.3% had good COVID-19 perception. But what was the major thing was almost half of the participants had bad perception about COVID-19, and that was a challenge to us. About 46 of them had bad perception that during the COVID-19, they should come to the blood service to donate blood. They might be contaminated. And we realized that those between the ages of 26 and 30 had adequate knowledge. And among the youth, and 31 and 40, they had it. So age category was significant to knowledge about COVID-19. Their response on practice and expectation, we also realized that we asked them what they were doing to protect themselves during the pandemic. And majority of them were washing their hands regularly. They were using face masks and practicing social distance. Just a few were taking some form of medication as immune boosters. When you asked them, they said they were taking either zinc tablets or vitamin C. And we also asked them what they expect the blood service to do to encourage them to come and donate blood during the pandemic. And most of them wanted the blood service to distribute face masks and sanitizers. They also wanted some form of education, if we should teach them how the mode of transmission of the COVID, how the disease, what kind of disease it is. If they get to know that, have that knowledge, I think that will overcome their fear, and it will encourage them to come and donate during the pandemic. They also expected the blood service to treat them, to give them a warmer welcome, and they expected a quality service. This is not normally the case in our parts of the world, in the Western country like Africa. When donors, especially with the hospital-based blood service, when donors come, we don't have the time to welcome them appropriate and give them the quality service. So when they go, they refuse to come back. They were also expecting that if the social distance could be practiced at the blood service,
Hello. Hello. And few of them expected that if there could be some incentive in the form of payment after donation, if you could give them something small to just motivate them, or if probably we should come to their doorsteps to come and take the blood, which was going to be somehow impossible for us to move to their various homes for blood collection. But we'll do it as a recommendation. So using a cut-off of 50%, we realized that about 88 of them had good practice, washing their hands, using the hand sanitizer, and also wearing the face masks. And their expectation, about 68.8 had high expectation during the COVID pandemic. We also realized that age category and the kind of hospital attended were significant to expectation, high expectation during the COVID-19 pandemic. And age, donor type, and the hospital attended was also specific, significant to perception, COVID-19 perception. We use a multivariate model. Being in the ages of 26 to 30 or 31 and 40, we realized that they had increased odds of adequate knowledge about COVID-19 compared to those in the ages of 17 and 25. And we also realized that donors who attended the police hospital and Konfano Teaching Hospital had higher odds of good perception about COVID-19. And those who attended the 37 military hospital and between the ages of 41 and above had lower odds of high expectation during the COVID-19. We recommend that if we are recommending if the blood services could distribute face masks and hand sanitizers to donors who come around to donate, it will help and it will also overcome their fears. And we also think more education should be done during the interviews. When they come, at least we can take them through the mode of transmission of COVID-19, how they can protect themselves, stay away from others, and practice the social distance. That will also encourage them. And the staff in the appropriate PPEs will also help them to come and donate blood. We recommended that the blood services should focus on the safety of blood donors and provide PPEs for donors and health workers in blood banks. And this will alleviate the fear of COVID-19 transmission among blood donors and the general public. Thank you very much for your listening.
Thank you very much.
So good afternoon now, everyone. I'm going to speak on the topic, as you can see, per the slide on the screen, clinical characterization of COVID-19 in Ghana. It's an interesting topic, and you can see from the list of contributors that it does require a lot of collaboration. I'm proud to say that this was perhaps the first COVID research that received approval from the Ghana Health Service Ethics Review Committee. Was submitted as early as March. As soon as COVID broke, we submitted this for ethical approval. We managed to get it thanks to the collaboration of several of us. So I'm just representing this large group and speaking to some of the work that we have done. So you can see on the screen there sort of a snapshot of all that went into the response to COVID in early 2020 when it broke the first time. So March 11, as I mentioned to you, there was a declaration of a pandemic. Before then, the disease had been given a name. This was February ending. And then on March 11, it was declared a pandemic by the WHO. And then we had our first two cases, March 12. And then we went on to do a bunch of things to try to control the disease, including school closures, travel bans, and so on and so forth. I don't need to spend too much time on that. What I want to focus on is here, which is what we did at the Ghana East Hospital, which is also where the Ghana Infectious Disease Center is situated. So we began as early as April 2020. That's when we started collaborating with them. That was pretty close to when the pandemic started. I'll go into some of what went into setting this up at such an early stage. But what I want to really press home here is the need for research during pandemics to be as nimble, as quick as possible, especially for pandemics involving infectious agents that are novel. So unlike Ebola, which we knew already, and other epidemics for other infectious diseases which we know, COVID, SARS-CoV-2 was hitherto unknown. And so while it had emerged in Wuhan, China, and we had gotten to know all that was involved with it, we knew that it was caused by SARS-CoV-2, its clinical presentation was still being understood. And there was also need to understand this from a Ghanaian perspective, not because the Ghanaian is a different kind of human being, but because we understand that there's a certain geographic variable which informs the clinical presentation, manifestation of diseases, and ultimately the clinical and health outcomes of diseases. And understanding this also helps you to put your clinical interventions and ultimately your public health interventions into perspective. So this is a snapshot, or an aerial view, actually, of the Ghana Infectious Disease Center, and which is here. And then the Ghana East Hospital is there with the red roofs. So I was there with my team, myself, Tony, and Joseph, to have discussions with the team there at the GIDC, the Ghana East Hospital, actually, and that's what you can see going on in the conference room, where we had to do some orientations regarding how we'll go about this data collection. Those were the times when, we would fly to Accra and we would be the only people in the hotel. I remember I went a few times, and in a few hotels I stayed in, I was the only guest. And guess what happens when you're the only guest? They give you the presidential suite. So it wasn't bad for me at all. I had a huge room to myself. Yes. So the rationale for understanding this is, as I've already mentioned, we need to understand how this pans out clinically. We need to do it rapidly to try to understand how things are working, but more importantly, to inform the kind of therapies that may or may not work. A lot of diseases would have physiological manifestations, clinical manifestations for that matter. And so once you're able to identify this, whether it's a cough, whether it's a headache, whether it's a diarrhea, you know what to put in so that you can improve the clinical outcomes. Many diseases will not be the pathogen itself that may cause the death or the morbidity, but often the effects thereof. So if there's a diarrhea-causing disease, it is the inability for you to retain fluids and lose more than would allow your body to sustain itself that will kill you. So arguably, if you're able to replace your fluids quickly enough, the presence of the pathogen should not kill you. And this is why it's really important that we understand how this works so that we can put in place the right kind of clinical interventions which will allow for good outcomes. So these are the specific objectives of the work that we did to determine the clinical features of COVID-19. I remember at this time, this was where in some parts of the world, including Ghana, just gastrointestinal presentation was becoming, or fast becoming, a feature of COVID-19, which hitherto had not been described before. And I don't think that we are done yet with trying to understand the clinical manifestation of COVID, because during the third wave in India, mucormycosis caused by fungus was actually a major clinical presentation of severe COVID, which hitherto was not something that had been identified before. Things like loss of smell and loss of taste, ageusia, were all things that had not been noted before. And as the clinical understanding of the disease progressed globally, we were able to add on to that list. So very important. Not only that, to understand the factors associated with the disease, to facilitate effective triage systems, and then ultimately to inform the development of clinical and other guidelines and policy recommendations for addressing the disease. All right. So I go on to how we went about doing this. First of all, we conducted this as a retrospective observational study. Essentially what that means is that we go back and just look at what records that we have or what is available. The most ideal would have been to do a prospective kind of study, and we are still struggling to move this into a prospective phase where patients are recruited real time as they come to hospital with COVID. But this has been rather challenging. So for now, all we have is the records of the patients. Our data is only as good as whatever records, clinical records, were collected at the time. And so the data was from all clinical records. Then we go on and we enter this into a data management system, specifically a REDCap, which we developed within our team. Our data manager, who we call the marvelous Kwekuduya, is he here? Okay. He's hovering around somewhere. Okay. So he set up the REDCap system, and we are very proud of this because we actually shared our XML files with a couple of other African countries which are using the same also to do their clinical characterization of COVID. And then we went on and analyzed this data using cross-tabulations to try and understand associations and also logistic regression to further understand how these variables interplay with each other and how significant they are in predicting two major things. One would, of course, be death, which is an ultimate state you want to avoid. But beyond death, one of the good proxies for morbidity is length of stay in the hospital. And so aside death, you also want to be able to predict length of stay. So that's what we did. So this is also a description of some of the information we collected. As I said, we did it more retrospectively, entering data from folders. Where we want to get to is really this, to enter data and to collect serial samples from patients. We're looking at doing a day 1 when they arrive, then day 9 and day 14, looking at taking, apart from blood samples, also stool, urine, and various swabs. The idea is that we have a high prevalence of comorbidities in sub-Saharan Africa for various kinds of infectious diseases. Our malarias, urinary tract infections, other respiratory pathogens, and our helminthiasis and several others could interact in very interesting ways with COVID. There were two schools of thought, for example, with helminthiasis, that some were arguing and showed scientific proof that it could actually worsen the outcomes for COVID, while others do show scientific proof that it could actually modulate or moderate COVID and give you better outcomes ultimately. So very interesting. There's a lot of work on how BCG vaccination might or may not influence outcomes of COVID. All these are things we need to understand. And it's in our part of the world that we have these really important comorbidities which need to be explored to understand. And the best way you can do this is to seek for them. Because if somebody comes to hospital with COVID, they're not going to tell you that I have a UTI also, I have so-and-so condition, until you actually look for it. And many of these conditions are chronic, even though they are infectious diseases, and until you go digging for them, you will not find anything. So these are the findings we had. 2,113 COVID patients. That's huge. It's by far the largest cohort of clinical data on COVID that we have in Ghana. And I'm happy to say this is the first time we're presenting this openly at a conference. The distribution by age was youngest 1 year, oldest 93, with a median age of 36, pretty reflective of our population distribution. The interquartile range was between 28 and 48 years. Male-female distribution, more males than females, about 60% males and 40% female, and 7 pregnant women were included in this. Not very much to make any conclusions, but COVID in pregnancy is a very important consideration. We particularly know in Latin America that this was looked at very closely, and the outcomes are not very beautiful for pregnant people. This is the distribution of nationalities that we have. Majority Ghanaian, of course, but we did have data from other nationalities, particularly Nigeria and some from North America and UK, and then from other African countries like Liberia and Ivory Coast, right? This unusual distribution is the fact that it's people who are highly educated who are most likely to go to hospital and to present themselves to be tested or to be hospitalized. Especially, we collect a lot of this data in the beginning of the pandemic where everybody was hospitalized. Once you test and you're positive, you are put in the hospital or in an isolation center. So this really does not reflect, I think, the reality of distribution of COVID in Ghana. These are the most frequently reported signs and symptoms, the usual cough, but also headache and fever as expected, and a bunch of other signs. This is perhaps more interesting, which is the risk factors. Risk factors we know very well, like smoking and asthma. Perhaps the most interesting one I find is alcohol use. Alcohol use was only second risk factor for COVID. And I don't think there's much literature on this, but it just shows that people who take in alcohol were at a higher risk of getting COVID. Complications by age group. The blue are your under 50s, the gray are your above 50, and almost for every variable you see an increase risk or increase number of people presenting for those who are above 50. Except for viral pneumonia. Ask me how I know. I don't know for sure, but it's what is in the folders. And then you get a few others for which less than 50 was higher. And then by sex, you can see clearly that the males were worse off. As we say in Alokapa, as a memebre. I think it really reflects on this. That time you say mabre, memesobre, and the data doesn't lie. All right. These are some of the other complications, ranging from bacteremia through to endocarditis, the pleural effusions. These are, again, your classic complications of respiratory illnesses, but also the strokes. Well, not surprising again, because we know of the coagulopathies that accompany COVID, because we got to know this much later. As I conclude, 15% of patients experience at least one complication per what I showed you. And there was also this male-female disparity where the males were far worse off, even the outcome of mechanical ventilation. When I say mechanical ventilation, all I mean is giving of oxygen or intubation. And this data set, only one person was intubated. We are still looking at entering data from other places where a lot more people were intubated as well, and hopefully we would be able to do better estimates of the risks for this. And then the duration of admission. The females, interestingly, seem to have a higher average length of stay, but this is biased by the fact that risk of longer stay than those who are less than 50. The overall mortality was 2.5%. As I said, higher male mortality than female mortality. And then by age group, you can also see that those who are above 50, way more mortality than those who were below 50. And then for predictors of death, and this is perhaps the most interesting slide for all of us, you can see the adjusted odds ratio of death if you are hypertensive was almost a fourfold, as opposed to, or compared to diabetes mellitus, which was a little lower, but still very high. And you can see how significant these values are with fairly convincing 95% confidence intervals. Being above 50 was way up there. And even though the confidence intervals are also very wide, even if you take the lower bound of 5, that's already high on its own. And then being obese also, I mean, obviously the data would be skewed, but again, significant risk of death if you're obese. And this really tallies with the global data that we have. So to conclude, I think I'll just skip this one because I've already spoken to these. And some of the impact is this COVID dashboard. So we created a dashboard again, our in-house data team developed this dashboard, programmed it from scratch. It interacts directly with the database, so it provides real-time information. When the data is entered, it's on the dashboard. We made this available to the government actors so they could see real-time what was happening with clinical data and make informed decisions as they moved along. This dashboard is still available, but there's limited access. And then also we run a healthcare worker survey under this, and Joseph Bonnet presented on this yesterday. Interesting findings. We're looking to publish very soon. There were challenges. I'm not going to all of these because of time, and I can see that the moderator is about to kick me off the podium. I'd like to say thank you also. We had a couple of capacity building activities, as you can see there with the Ghana East Hospital and the GIDC. And just to say a big thank you to all our sponsors and supporters from right here in Ghana, through the Biennial Knox Institute and to KCCR. And I really want to take just a few seconds to say a big thank you to my team that has worked really, really hard and continues to work hard. A number of them are here. I'd like just to clap for my team because they've really done a great job. Thank you very much.
Thank you. Thank you very much, Dr. Moesi. That was quite insightful presentation. We'll call our next, as I said earlier, after the presentation, all the presenters will come forward. There is a lot that I believe, you want to ask. So we call on the next presenter to come forward from the Disability Department. Saki E. You have 10 minutes.
in academia where your studios are there, you don't mention your title, okay? But Dr. Immanuel Saki for the students, for my seniors and colleague Immanuel Saki. Okay, as you see on the slide, my unlike or contrary to all most of the presentations in this conference, this is not a research outcome. Okay, this presentation is not an outcome of research that is going on or has been completed. It's a concept note. Okay, it's an idea. It's a conceptual framework. It's an idea that is pregnant. So it's undergoing antenatal care. So if you have any care to give it, then you put an idea to polish it. Okay. Okay, as you see on the topic, I frame it innovations towards disability inclusive COVID-19 safety protocols. I'm from the Department of Health Promotion and Disability Studies at the School of Public. My focus is on the disability aspect of this of the to begin with, is a World Health Organization, WHO. We have about 466 million. Okay, people out of the 7.9 billion global population with ear impairment. Now, there are various categories of ear impairment. We have congenital. And those in pharmacology, you take note of this. There are certain drugs, autotoxic medications, even though they might be good for certain bacteria or infections or virus infections. This is just the background. Now, has led to, has made the compliance for public health. However, prescribe a medication that is made to provide cure. And you know that certain medication may have side effects. It is unintended consequence. Because you might be taken to court for medical negligence. So that's why I say it's an unintended consequence. Nobody intends foresee this, but it almost become a reality. So let's look at it in details. I would like to acknowledge the presence of the provost of the College of Health Sciences at KNUST. Now, I'm going to about over a little over 700,000. Now, in the region, they are high. or visual impairment or blindness is the number one top of disability in Ghana, followed by physical disability. Then maybe mental health come. Then the fourth category is hearing impairment, which is deafness. Now we are looking at the COVID-19 measures, the safety protocols, the state which it imparts on access to information and communication for the deaf in Ghana. Not in Ghana, global. It's a global phenomenon. Now, these figures I've given, these statistics are actually contentious because I was part of a team that analyzed the 2010 census. Proper account of the 2020 sources, and we are likely to get a more an improved statistics. Now, what is the problem statement or the description of the problem that this concept note or the conceptual framework seeks to attain? As I mentioned earlier, it is not an ongoing research. Neither am I presenting the results of a research, but it's, as I said, it's a pregnant idea. Okay, it's a conceptual framework, it's a concept note. Now, for the problem statement that we proceed that the use of non-transparent face masks has exacerbated the communication barrier for information access for the deaf and hard of hearing population, not only in Ghana, but globally. Now, why? Because this is probably because the majority of hearing impaired people rely on lips reading. They read lips. Even though they may be using some gadgets like cochlear implant, which is the one I'm using now. Okay, it's different from ear aid. Ear aid is not surgical, but cochlear implant is a surgical. Okay, in a device, a computerized chip into the head and stuff like that. It's more high tech, a high tech kind of a surgery, and all kind of people with hearing impairment who rely on any assistive device rely on lips reading to compensate in order to be able to access information and communication or be able to communicate with hearing people. Now, what happened? So this is the problem statement. Now, this has led to a tension between the COVID-19 protocols and disability rights, because globally the deaf population, as I mentioned earlier, you see the global size is very high, and they have been contesting, they've engaged in advocacy, like other disability groups, like the gender movement, who are fighting for women's rights. And one of the things they contest is that, okay, so more or less we have disability rights. Okay, now these rights, if you look in the broader framework, at the level of the United Nations, at the level of the World Health Organization, at the national level, there are legal regulations, constitutional provisions. The Ghana Constitution made provision for that. The UN Convention for persons with disability also make provision for that. Ghana has ratified it, so it's binding. Now we also have national disability, which is a national disability law. These laws or these regulations grants certain rights to people with disability in terms of access to healthcare and political access, almost every socioeconomic aspect. Now, what happens is that let's go. Okay, so as I said, that there is a tension between our problem is that there is a tension between those disability rights and the compliance to the COVID-19 protocols. Thank you for the timing. So, what is our hypothesis? What do we hypothesize for which we want to seek confirmation through research? Now, our hypothesis is that the use of non-transparent face mask has exacerbated or exacerbates the communication barrier between the deaf and the hearing population. Set objectives. We want to examine the extent to which the use of non-transparent face mask as COVID-19 safety protocol affects the access to information and communication for persons with hearing impairment. Second is to examine the tension, that what I was talking about, the tension between the use of non-transparent face mask and disability rights. Thank you. Now, the third is to generate evidence to support the proposal for the use of transparent face mask. Okay, this is a Ghana issue, but the findings of this research, probably, if we are able to do cross-country analysis, we can generalize. We can generalize not only in Ghana, but even at the national level. We go for the literature review. We have some evidence across the various countries about the challenges that deaf people are facing globally. Now, the third is to, okay, so what is the proposed methodology? We want to use quantitative studies. Okay, we design a consensus method using Ashanti region as a case study. Now, for our sampling, it will depend on the outcome of the census and availability of donor funding, because we intend to put this. I intend to put this research project under a wider framework, a wider project that is promoting assistive devices in Ghana for the rehabilitation of hearing impairment. But for now, the face mask is not a assistive device. It's not considered as one, but it is almost becoming, because of the current preliminary investigations, what the evidence available. 1 minute, boss. Now, so as I said that the kind of the sample, the population size we may use may depend on the outcome, because the data we have now on the deaf population in Ashanti region is outdated. The national data is outdated, and even when it was not outdated, it was contested. So we have to wait for the outcome of the 2000 census. There are certain districts we look at. Seturi is in the Ashanti region one of the highest prevalence of some of the methodology. Now, finally, we confirm our hypothesis. Secondly, we also the same because it is taking as given. Nobody has thought of this. Okay, the Ministry of Health thought maybe the protocols are okay, but there's a subpopulation that may be about 10% of the population that are suffering because of the protocols. So they may have to revise their safety protocols. But to do that, you need evidence. So we may use the evidence from this study. I said may, because it may happen that the study may not necessarily validate the hypothesis. In that case, we will draw. But if it happens, then we have to engage the Ministry of Health so that they revise the safety protocols. Finally, the conclusion, what is the implication for the study? The implication is that there is a tension between disability rights and the use of and compliance to the COVID-19 safety protocols. Why is there the tension? There's a tension because of majority and minority rights. Okay, the deaf people are a minority group. The majority rights are also there. You also have a right. If they invoke the disability right, you can also invoke the national constitution, because you need to protect yourself. When I came here for admission, for appointment as a lecturer, the pandemic has started. And then it became challenging. I told the vice chancellor that maybe I had to go, because I need to read his lips in order to go through the process of interview to get okay. So my head of department, who is now my mentor, Professor Duse, had to write for me. Whatever they say, they write for me. He write for me. So I respond. Why? Why? Because they also have their right not to be infected. So there's a tension. Now, if I invoke the disability right and maybe take KNUST to court for not being disability sensitive, but KNUST already has a disability policy. KNUST has a gender policy. Now the people also need to protect themselves. So why, because of me alone, you should all remove your face mask to speak to me? Do you understand? So that's a tension, and we need to.
Thank you very much. Thank you very much, Saki. Thank you very much, and thanks to all the presenters. Subsequent maybe presentations where we'll have detailed time for some of these deep thoughts to be presented to us. We are supposed to go for lunch at 1:50. We are a bit almost over time, but I'll take 4 questions from you, just 4, and just be snappy. Mention the name of the, not the name, but just point to the presenter, if you can remember the topic, and then, so, mic for you, please. Anybody who wants to contribute?
To Dr. Moise. Doc, thank you for a nice presentation. You did indicate that alcohol consumption was second to hypertension as risk factors in your study. When you're looking at the odds ratio for alcohol, for the other risk factors, diabetes, hypertension, and so on, you left out alcohol consumption. I don't know whether you have that data that could inform, because prior to the safety protocols, there were these rumors that taking a certain concentration of alcohol actually could prevent COVID. So it would be interesting to have that data that explains that even the alcohol itself has a risk factor in terms of severity and then outcome. Thank you.
Thank you very much for your question. Regarding the alcohol consumption, indeed, I pointed out that we realized it was associated with those who came down with COVID. But what I showed in terms of the adjusted odds ratios was risk for outcome of death. So while the alcohol consumption was a major association, it clearly was not well associated with getting the COVID, but wasn't associated with death from the COVID. But I just want to look at it in terms of what alcohol consumption. Increase your risk possibly of being susceptible to COVID, and by extension, your risk of death from COVID. But by the way, there was no significant immediate relation between alcohol consumption and death from COVID. Again, stop now before.
Okay. Any other question?
Yeah, thank you. This goes to Doris, the second presenter. Why did you using multiple choice instead of allowing them to give their own answers, but you rather suggest some answers for them?
Thank you for the question, sir. We added the questionnaire to the already existed donor screening questionnaire, and we didn't want to waste much of their time. So we grouped them into multiple choice so it would be easier for them to answer.
You don't look convinced.
No, it's not a follow-up, but I want to know why you think the use of bed linen was just a perception of a transmission of COVID rather than a real situation. Because is it not appropriate for the blood donors to be afraid of sharing bed linen?
Bed lining. No, the question. Please, the question again.
Yeah, the question is, in the presentation about blood donors, eyes in the same bed and follow up by another patient, they will contract COVID. And you say it was just a perception. Is that not real?
Thank you, sir. Yes, we were changing the best bed. We had disposable ones, but they thought we were using the same bed sheet for every individual, because when the other person gets up, we change the bed spread. We're using disposable, so it was a perception, thinking we're using the same bed spread for all donors, but that wasn't what is going on during the pandemic. We do change them after every donor. Thank you.
Okay, so we take the last question, but two announcements. Okay, two announcements. One is that evaluation forms are going around. Please do well and fill it before you go. The second is that COVID-19 vaccination is ongoing. So once you step out, the AstraZeneca vaccine is out there, you can take it.
Changing bed sheets between donors, where the donors wearing masks, because this is respiratory. So if the person was maskless and release droplets, the changing of bed sheet will not give any help at all.
Please, they were all wearing masks. You can't enter without masks.
They were all wearing masks. So, but at least it's a perception issue that we try to inquire about.
Thank you very much, Dr. Moisi, for your talk. I'm just wondering, the CVD risk factors, the hypertension...
Please, louder so that the rest can
Okay, sorry. Thank you very much for your talk, Dr. Moisi. I'm wondering, the predictors of mortality, I saw hypertension, diabetes, age above 50. Do you have, what's the picture like for those less than 50? Is it a case that they are not dying that much? And then my other question is the cardiovascular risk factors, diabetes, hypertension, they lead to cardiovascular diseases, which sometimes if you do an ECG, you may find. Do you have data on such patients? And in the future, are you looking to do anything like that? Thank you.
I think these are important questions. We were severely limited in what we could do with the data because it's all retrospective from the folders. So we chose to dichotomize risk of death by less than 50 and greater than 50. And there was a much higher probability of death if you are above 50. But of course, this is in a way correlated with the much higher probability of comorbidities, which in themselves are risk factors for poor health outcomes. So it's not surprising, but then you see clearly that significant risk of death when you are older. It would be nicer if we were able to further look into the data within the less than 50 age group and then within the greater than 50 age group. Well, we haven't gone that far just yet. ECG was not part of a lot of the data that we had available. So I can't comment on that. But there are a lot of other routine investigations that could have been conducted. ECG, you know already that radiological investigations were actually a major predictor. There are several radiological investigations, particularly CT, which turned out to be a better indicator of COVID than some of the clinical signs and symptoms. And even sometimes people turning up with PCR negative for one reason or the other, with the radiological findings being so strong, and eventually repeat tests are done, it's PCR positive. So I do agree. I mean, if we had the luxury, you'd want to do some of these tests to give you a better view of what it could be. But we don't have these. So it just points to the need for more stringent clinical investigations to really understand how things are panning out in Ghana. So thank you.
The third presenter, we are not getting any questions. So last question, but I think for Hammond, somebody needs to ask a question so that he will have something to tell us.
Sorry, mine also goes to Dr. Moisi. Please, I acknowledge your limitation, but I'm just wondering why hypertension was the leading risk factor. Is it like maybe the diabetic who were also hypertensive were counted as hypertension, or hypertension has a different feature that is predisposing them to the COVID?
I think it's a good question, and when we are done, because of time, I can show you. We actually have a nice Venn diagram which shows the intersection of hypertension, diabetes, and alcohol consumption, and you see the proportion of individuals who had all the three, and what that really meant. But these were the top risk factors associated with getting COVID, not necessarily dying from COVID. We have that intersection, which shows those who had only hypertension, those who had only diabetes, and those who did only alcohol, and the various intersections of the Venn diagrams. So yeah, we have that available. Yeah.
Any question for the innovation, disability? Yes.
I don't have a question for him, but I would want to say that I would be happy that there will be donors for them to go through the research, because it's an interesting one, and I would want to know how persons with disability. He wants to read my mouth. Yes, I said that I'm happy and I'm interested in the study, because I want to know how you would get the results after getting donors to go through the research, because it's going to help. It looks as if all the things we are doing, we are looking at those who are, in quotes, okay. But we are not looking at that vulnerable group. So your research is quite good, and I think that we should applaud you for that. Thank you.
Thank you very much. And I think for all of us sitting here, I mean, mask, whatever I'm saying, is a right. Is it against the disability right of a sort? Let's hope maybe subsequent conferences we can improve on this and have gadgets that can enable us to communicate well. Thank you very much for coming. It's lunchtime. I wish you all the best, but remember that the COVID vaccine is out there. Oh, please, we are going to the auditorium for the closing ceremony, after which we go for lunch. Thank you very much.